Our final panelist tonight, this afternoon, is, just feels like tonight because I'm still on Ottawa time, is Dr. Thomas Kerr. And I think many of you have probably seen Thomas quoted in the media. He has spoken extensively, not only in Vancouver, but across the country. Thomas is a research scientist with the BC Centre for Excellence in HIV/AIDS and an assistant professor in the Department of Medicine at UBC. He's the principal investigator of several large cohort studies involving people who inject drugs, including what's called the VIDUS study, which is the Vancouver Injection Drug Users Study, which has been going on for how many years, Thomas? 10 years. So it's a very important piece of research that's now been going on for a decade. And Thomas has also been, a key focus of his work has been the scientific evaluation of insight. So please welcome Thomas Kerr.
As a researcher and a former frontline worker working in the area of HIV/AIDS, I've decided that today I'd like to focus my comments a little bit more around the international and national HIV epidemic affecting people who inject drugs, and then to relate that a little bit to the current drug policy situation. I'm sure it's not news to anyone in this room that injection drug use continues to fuel the global HIV pandemic, and we now know that close to 1/3 of all new HIV infections occurring out of sub-Saharan Africa are in fact attributed to injection drug use. But if we actually turn our attention to the countries with the most explosive, the most fastest growing epidemics, that is countries in Eastern Europe and Central Asia, we find that the sharing of injection equipment now accounts for more than 80% of all new HIV infections. In Vancouver here, we know very well how explosive and how unique HIV epidemics are when they occur among communities of people who inject drugs. In Vancouver in 1996-97, researchers from our center at the BC Centre for Excellence in HIV/AIDS documented what has been described as the most explosive HIV epidemic ever observed in the developed world. It happened a couple blocks from here in Vancouver's downtown east side. During that year, an annual HIV incidence rate of 18 to 19% was documented, and in simple words, that means about 18 or 9% of all injection drug users in this community became infected in 1 year. I agree with the Vancouver Area Network of Drug Users when they said, certainly if we went up to City Hall on any given day and found that 18% of people were becoming infected in a year and a person was dying of an overdose, lots more would be done. Unfortunately, harm reduction services, which I think in the case of injection drug use driven HIV epidemics are HIV prevention programs such as needle exchange, they've really been long identified as essential components of effective HIV prevention strategies. The World Health Organization recognizes harm reduction as an essential part of any effective HIV response, as does the United Nations. And while scientific consensus has been reached regarding the efficacy of programs such as needle exchange and methadone, these interventions unfortunately remain very controversial. In the United States, for instance, while close to 1/4 of all new HIV infections have been attributed to injection drug use, there remains a federal ban on funding for needle exchange programs. In the Russian Federation, from 2002 to 2004, funding for needle exchange programs has fallen 29%, while the prevalence of HIV infection among injection drug users in that country is up to 60% in some areas, and methadone remains illegal. If we look globally, though, among people considered to be vulnerable to HIV infection, including women at risk for heterosexual transmission, men who have sex with men, it is actually people who inject drugs who have the lowest level of access to HIV prevention programs globally, with less than 10% of injection drug users globally having access to programs such as needle exchange and methadone. So why would we have such a situation? We have a raging problem. We have an HIV epidemic that continues to be very dynamic and active and in some areas explosive. We have a large body of scientific evidence demonstrating the efficacy of programs that prevent HIV infection, and yet very few people have access to these programs. I think the main reasons really come down to politics and law. And while there certainly are many political drivers, I think there's really three that deserve special attention. First, in Canada, as in many other countries, are signatories to various international treaties and laws which take an enforcement-heavy, get-tough approach to drug use. Unfortunately, these treaties were developed long before HIV was discovered. They're irrelevant, they're out of date, and they need to be revised. Second, the enforcement community really has much to lose and lots to gain by resisting a demand reduction approach. Currently, 78% of all federal drug strategy monies goes to the RCMP, the Department of Justice, Corrections, and the Canadian Border Services. And as in the United States, where the Prison Guard Union has become one of the country's most powerful political lobbies, what we're seeing under our new government is a rise in the power that the Canadian Police Association and the RCMP has in lobbying for policies that they prefer. And don't be fooled by recent statements by our federal government suggesting that 2/3 of their new anti-drug strategy is going into prevention and treatment, and therefore they have a balanced approach. A brilliant young policy researcher, Cora DeBeck, who works with our research group, has already done an analysis looking at the new monies, adding it to the existing monies, and found that, in fact, the values in terms of the percentage of funds given to enforcement, prevention, treatment, and harm reduction have only moved about a percentage point. Still, over 75% of funds go to enforcement, and now harm reduction has gone from 3% to 2% of federal funding. I think the third driver relates to the fact that politicians feel that they have little to gain by taking a health-focused approach to drug use. That sort of that fear tactic that Libby was talking about. So really, both in terms of votes, really I think there are a few politicians like Philip who are willing to risk their political career in the pursuit of doing the right thing. But there's also this international relations problem. Through a Freedom of Information request, a recent analysis was obtained that's focused on the risks and benefits of renewing the supervised injection site. This analysis was conducted by the Office of Canada's Drug Strategy, and unfortunately the analysis concluded that the single greatest risk associated with renewing Insight was offending the international community. In other words, the people working in the Office of Canada's Drug Strategy are more concerned about averting the risk of offending the United States of America than the risk of closing a program that has been proven to reduce HIV infection and save lives. Under Canada's current drug strategy, it should also be pointed out that innovative programs like Insight and the North American Opiate Medication Initiative are limited to small pilot studies that are held to a remarkably high standard of evaluation. Meanwhile, projects such as the school-based prevention program DARE, run by the RCMP, continue to receive an increasing amount of funds through Canada's drug strategy despite a lack of evidence supporting their efficacy. There was recently a meta-analysis done in the American Journal of Public Health, and a meta-analysis is one of the more powerful research techniques available to researchers where you can pool the results of studies to come up with a single finding regarding the effect of a program. These authors really found that there was two types of studies when it comes to DARE. Programs that show that DARE has no effect, and programs that show that drug use actually increases in the presence of DARE. Collectively, these researchers concluded that DARE was found to have really no effect and is not an evidence-based program. On the other hand, the formal scientific evaluation of Vancouver's injection site has objectively documented in a number of peer-reviewed medical journals such as The Lancet and the New England Journal of Medicine a significant range of positive public health and public order outcomes. Yet, even with established findings, including increased uptake into detoxification programs, and reductions in needle sharing and overall public order improvements in the surrounding area, the federal government continues to play politics with people's lives by saying that more research on Insight is needed, and also by halting new injection sites elsewhere in Canada. The Minister's comments, the Minister of Health's comments in September 2006 that quote, right now, the only thing the research to date has proven conclusively is that drug addicts need more help to get off drugs demonstrates only one of two things, and that's either that the Minister has a limited understanding of the scientific evidence derived from the evaluation of insight, or he's being disingenuous. As a researcher, I rely on research funding to do my work. It's interesting work, it's stimulating, and we like getting funded. However, when our research group presented to Canada's Drug Strategy Office and the RCMP and representatives from the Minister of Health's office, we actually said that we did not feel that a scientific exemption was warranted, that really more research wasn't needed, that this was arguably one of the most over-evaluated public health programs in the history of Canada. Find another innovative public health intervention that has 25 peer-reviewed published studies supporting its effectiveness. Despite the fact that we like getting research money, we said, really, the research could stop here now. This has obviously been shown to be an effective part of, a small effective part of the overall solution. Now let's start turning our attention to other things that may work. By removing harm reduction from Canadian drug policy, the government is really denying and limiting injection drug users access to essential services, and clearly is thereby violating Article 12 of the International Covenant on Economic, Social, and Cultural Rights, which is the right of every person to enjoy the highest attainable standard of physical and mental health. Protecting human rights is an important policy objective, and the abandonment of such principles, in my opinion, does not reflect the social and cultural values of Canadians. It has been over 4 years since former U.S. President Bill Clinton publicly acknowledged that he was wrong to withhold federal funds for needle exchange programs in the United States. So I ask, how long will it take before the Government of Canada expresses the same regret? More importantly, how much unnecessary suffering and new HIV infections will occur before our political leadership finally embraces evidence-based public health principles in the fight against HIV/AIDS? Let's hope it's not too long before they do the right thing. We can do much better, and we must. Thank you.